Good morning, everyone, and welcome to Tyro MDS. It is our Friday morning program, and we truly have an outstanding tumor board set up for this morning. We encourage you to send in your questions this morning, as we will try to get to those as best as possible before the 9 o'clock. So feel free to send them in on the chat, and we'll do our best to get to those. So Mike, let me hand this over to you, and I want to welcome all of these wonderful panelists and thank everybody for joining from all over the world here.
Terrific. Thanks, Mark. And welcome to the University of Michigan team. We'll introduce you guys in just a second. I'd like to go around the panel really quick and just have you guys give me a sentence about who you are on order on my screen. Dr. Hartl.
Oh. Hi, I'm Dana Hartl. I'm a surgeon at Gustave Roussy Institute in France, and I specialize particularly in thyroid cancer surgery. Thank you for inviting me.
Dr. Pattison.
Hi there. My name's David Pattison. I'm a nuclear medicine specialist at the Royal Brisbane and Women's Hospital in Brisbane, Australia. And my particular area of interest is in radionuclide therapy of endocrine tumours, so thyroid cancer and neuroendocrine tumours.
Awesome. Dr. Brandwein.
Hi, I'm Margaret Brandwein Weber. I'm Chief of Pathology at Mount Sinai West. I'm a head and neck pathologist, and I work with Mark.
You poor thing. Dr. Khorsandi.
I'm Azita Khorsandi. I'm a radiologist at Mount Sinai.
And Dr. Newbold.
Oh, hi, I'm an oncologist in London at the Royal Marsden, specializing in head and neck and thyroid.
All righty. And Naifa, Dr. Busaidy, did I get you?
Hi, I'm Naifa Busaidy. I'm one of the endocrinologists in Houston, Texas at MD Anderson Cancer Center.
Fantastic. And Dr. Esfandiari.
Okay, my name is Nazanene Esfandiari. I'm an endocrinologist at the University of Michigan.
Beautiful. Dr. Wong?
Hi, my name is Kakit Wong. I'm a nuclear medicine physician at the University of Michigan.
Awesome. And Dr. Worden, I'll let you introduce yourself.
Hi, Frank Worden. I am a medical oncologist at the University of Michigan, specializing in head and neck and thyroid oncology.
Awesome. Fantastic. Welcome, and thanks to everybody. I think our first case is going to be presented by Dr. Esfandiari. So let's go ahead and get started with the first case. Nazanene?
Okay, so I have this 44-year-old woman with a history of hysterectomy and bilateral oophorectomy for endometriosis in 2012 and history of Roux-en-Y gastric bypass in 2005, who underwent tightening of the stomach pouch in July of 2021. A month later, he presented to the ER, local ER, because she was having a lot of abdominal pain. They did an abdominal CT, and they did not really find any abnormality in the abdomen and pelvis explaining the pain, but they noticed that she had several lung nodules. That abdominal CT was followed by another chest CT, and that confirmed several bilateral lung nodules, and the largest was 15 millimeter in the left lower lung. After that, she had a biopsy of the left lower lung nodule in September of 2021, and that was read as a benign thyroid nodule. I did not write in the slide, but she also after that had a thyroid ultrasound, which showed only two thyroid cyst nodules. Then they did a lab, TSH was normal at 1.63, thyroglobulin was 40.9, and there were no thyroglobulin antibodies.
Okay, hold on here for me for just a second. Dr. Busaidy, we all know this is going to be thyroid cancer because we're a thyroid cancer conference, but it's a benign nodule in the lung. I mean, I assume MD Anderson just says we don't see benign thyroid nodules in the lung. What are you thinking here, Naifa?
Yeah, so this is a really interesting case. So whenever we see thyroid tissue in any other body part, we assume that it's thyroid cancer because it's not in the right place. And thyroid cancer can look very benign because they're just very well differentiated. They look like follicular cells, follicular tissue. So that's sort of how we explain it to the patients. We need the workup of the thyroid itself, but normal thyroid tissue does not belong in the lung.
Margie, help me there. I mean, when's the last time you signed out benign thyroid from the lung?
Okay, I gotta say, I've been a little stunned to hear the difference between how people will tell me what a report read and what the report actually read. Following me here? Okay,
Yeah.
fine. So I'm certain that the person who signed out this biopsy said something like histologically benign thyroid follicular tissue, please consider. blah, blah,
Right.
blah.
Because it's just a description of what you're looking at underneath the microscope, right?
Right.
And probably a reflection.
You don't leave a report like that.
Yeah, but it's more fun on the panel if we do it that way.
I know.
And it's always an outside hospital. It's never us, right? So I hope this didn't come from Memorial to Michigan. Okay, so we've got some well-differentiated thyroid in the lung, and we're all kind of paying attention to it. Okay, Nazanene, go ahead.
So then she came to our institution for a follow-up or for a second opinion. We did repeat the chest CT, and that was almost 6 months. 6 months later. And basically the lung nodule was stable there in terms of size. There were 4 nodules in the left lung, which were all in the lower lung, and there was 1 in the right lung. No new nodules. Then we asked those slides from that lung biopsy in the other institution. So we reviewed them in our institution, and our reading was metastatic follicular cell thyroid cancer, well differentiated, and then immunohistochemical staining showed positivity for TTF1 and thyroglobulin. There was no BRAF mutation. Then that patient underwent a PET scan in April of 2022, and that basically only showed lung nodules. There were 3 lung nodules with a max SUV between 2.6 to 4. And there were other nodules, but they said they were very small, and there was no FDG avidity at that time due to the size.
David, the role of PET scan, I mean, we think we're probably dealing with a well-differentiated thyroid cancer here. Should we do a PET scan? Should we not do? How had you been thinking about it at that point, David?
Yeah, look, at that point, we've surveilled those lung nodules for a couple of months. There's been no progression. The report is reading as well differentiated thyroid cancer. So we're expecting it to be, reasonably indolent in its behavior. This fits with disease that would be relatively, non-FDG avid or mildly FDG avid, as we'd characterize that sort of SUV range. Personally, I find in every case of metastatic thyroid cancer, it's helpful to do an FDG PET. I guess potentially I'm a little bit biased, but it may not necessarily, there's a lower yield in this setting, but it certainly helps. It's another piece of the puzzle. And it, it kind of confirms what we expect. There's sometimes you can get disease heterogeneity, sometimes things can be missed, but it's sort of everything all lines up at this point with well-differentiated.
In these odd cases, it's provided us some information. Okay, Nazanene, keep going.
Then we did the I have to say patient wanted another biopsy. So we did the biopsy of the left lower lung nodule again in our institution. And the reading was thyroid tissue with microfollicular architecture, metastatic follicular carcinoma is favored. And that's the slides.
So Margie, any comment? It's never fair to have you look at a thing, but what do you think here?
Sure. Well, many, metastatic follicular carcinoma favored because I'm just trying to read behind the lines. Follicular variant PTC could also be a possibility. And I've seen many a case where, presents like this with a biopsy. The biopsy, you don't see the nuclei of PTC, but yet when you take out the thyroid, you actually see the nuclear PTC features. So on a biopsy, I would not really hold store on whether or not it's follicular carcinoma or PTC, follicular variant, but say it's one or the other, until we got the molecular studies.
So Naifa and then Kate, because we got 2 different parts of the world here. In the setting of metastatic thyroid cancer, you're doing the biopsy. It's easy enough to order fancy molecular testing if it's available. At MD Anderson, would you have automatically done fancy molecular testing on this one? And then Kate, what would happen in England? Naifa?
So it depends on who you ask. The testing, when to do molecular testing, oftentimes there are some who feel that whenever someone is noted to have metastatic disease, let's plan for the future and do molecular testing. It may not change your management right today, but in the future, there may be some target that one can go for with systemic therapy. There are others who feel that you wait until you actually need systemic therapy, because the purpose of the molecular testing is twofold. One is it's for prognostication, and 2, it's for therapeutic. But I think it's much more often used in the therapy session, in which case we would wait. We could order it, but it doesn't mean we act on it now.
Gotcha. Kate, what are you guys doing?
Yeah, we're sort of in a transition period at the moment, but generally we don't order molecular profiling until we've got a patient who becomes iodine refractory when we're discussing differentiated thyroid cancers. But sometimes if you've got a slightly unusual presentation or you're wondering whether you may be already at that point and needing something other than straightforward standard treatment, then we may do it again, as Naifa says, just to sort of bank that information.
Yeah, I think part of it is availability and how easy it is to do, and can it be paid for, and all that sort of stuff. It's we're biases, like David likes a PET scan. We like molecular testing because it's just a checkbox and we can get it. Okay, let's go ahead.
So we did check the next generation sequencing on that core biopsy, and it showed an NRAS mutation. And therefore we said, okay, that's consistent with a follicular thyroid carcinoma for us.
So Naifa, did that help us? Did that make sense? Is that what you would have predicted? But when you get that result back, kind of what are you thinking there?
So the NRAS mutation is a mutation in the MAP kinase pathway that can be found on benign thyroid nodules as well as thyroid cancer. So the NRAS mutation itself doesn't necessarily tell me that, but I think given the clinical situation that it's thyroid tissue, well-differentiated thyroid tissue in lung, we're thinking that it's metastatic follicular thyroid cancer, and NRAS is actually the most common mutation that would be found there. So it's information, but this is not itself targetable. So it just sort of, I guess, add to the diagnosis, but doesn't necessarily change any management at this point.
Gotcha. Okay, so let's go ahead and see where this case goes.
Okay, then we ordered the thyroid ultrasound in our institution, just make sure we don't find something different. And no, we saw the same thing. There was one nodule in each lobe and they were cystic. So we sent our patient to have total thyroidectomy, and the final pathology was just multinodular hyperplasia with no foci or focus of thyroid cancer.
Dr. Hartl, you do a surgery for metastatic thyroid cancer and the path report comes back no thyroid cancer. What's your first call to the pathologist? What are you thinking here?
Well, yeah, usually that can happen. It really can happen. And with our pathologist, I'm not going to call her and say, oh, look more closely, because I know that Abir looks very, very closely. So no, that doesn't surprise me. Although this is so well differentiated that maybe it is sort of, I don't know, I'm not a pathologist, but it might be sort of hidden in there somewhere. Anyway, it doesn't surprise me. I wouldn't say, oh, you did a bad job.
Yep. Margie?
Well, okay, I got this. Okay. So now look at your hand, okay? The first way that you know that this is a hand and not something else is not by seeing the veins and the bones, but seeing the difference between your hand and the rest of the surrounding. That means we see things, we identify things by their contour, by their shape, by the contrast. So we identify things according to the contrast with the surrounding field, right? So when I was just a child and I saw my first follicular thyroid carcinoma, I was kind of stunned, right? On how the cellular level and how the architectural level, it looks so normal and yet it's so evil, right? So now there are two kinds of follicular carcinomas. There's two flavors. There's minimally invasive and there's invasive. So minimally invasive, easy, right? You have a nodule, the nodule has a capsule, and then you see one or more, foci of capsular transgression, you see vascular invasion maybe, et cetera, et cetera, et cetera. When you have the other flavor, right? When you have follicular carcinoma, invasive, you don't identify a nodule, right? You see a follicular carcinoma throughout the thyroid. And so since it looks normal, how do you identify it? By finding areas that prove that it's actually invasive. So you're looking at thyroid invading into thyroid. And I tell you, it's sometimes not very simple. And so some of my reports on, follicular carcinoma, invasive will say things like, invasion is best documented on slides A, B, C, D, whatever, because I could look at slides and it's all cancer, and yet you have to believe me on it. I can't prove it to you. So that's the first thing that came through my mind. you know, when I read this report. And that's my story, and I'm sticking to it.
Yeah, I think Dana's original comment of we see this, right? I mean, you want to make sure the pathologists look at it, but this is probably a well-differentiated follicular-derived thyroid cancer. And I would assume, David, you'd be pretty excited to do radioactive iodine here. You'd be thinking this is a tumor that likely would be helpful, right?
Absolutely, absolutely.
And how would you do the radioactive iodine on this one, David?
So with this one, we would use, knowing that it's metastatic disease, you know, our standard protocol is thyroxine withdrawal. And depending on the circumstances, sometimes we'll do an I124 PET prior to that to look at dosimetry. And in this case, you know, we probably would, and then we'd proceed with I131 after that. But actually, for the first dose, we'd probably give, you know, just about 4 gigabecquerels, because there may still be a significant thyroid remnant behind.
And 4 giga
It's about, just around 100 millicuries.
Gotcha. Naifa?
I just wanted to add, when the thyroid is taken out and we don't see obvious evidence of thyroid cancer, the other thing we think about is struma ovarii. And this patient did present from the gynecology clinic. I'm assuming that I would have reviewed that pathology to begin with, but at this point, I would probably go back to the gynecologist and the pathologist and look at that. Most struma ovariis are papillary thyroid cancer, but there are a handful of them that are follicular thyroid cancer. So it's just something I would have thought about, that's all.
Yeah, you and I think too much alike. That was the email that I sent back when I got the case. So that's
we have tried multiple times to get those slides. We haven't been able, and even prior to this, I tried again, and still we haven't received it. So
yeah, so that's on the ballpark. All right, let's finish this case because I want to talk about when to give the next dose of radioactive iodine. So take us through the rest of this, Nazanene, and we'll finish up with that last issue.
We made the patient hypothyroid, and we did a pre-therapy scan. And on the pre-therapy scan, you can see several long nodules in the left lung, and some you can see in the right. And then we did with the SPECT CT to again show the same thing. And we had the fusion study, then really you can see all the nodules that you can see on the top row. And then when you look at the fusion, you can see all of them.
Let me pause for just a second. Dr. Khorsandi, we love these fusion things. I mean, how good are the CT scans when we do the fusion things? Is it just for localization? Can you tell me size and that sort of stuff? How do you think about these fusion ones?
I think they're outstanding. They're great to have them. It basically summarizes the anatomic, it's a great anatomical tool. Yes, you can measure them on a good CT, and if it's done quality with, it won't be as, you know, it's not a high resolution CT chest, but absolutely you can measure it and you can localize the images.
Okay, so go ahead, Nazanene.
Okay, then she received 261 milligram of radioiodine in August. At the time of the pre-therapy scan, she was hypothyroid with TSH of 151 and the thyroglobulin was 179. After the treatment, she was started on levothyroxine 200 microgram daily. Then the post-therapy scan just basically showed the same nodules, but we can see them much better, but nothing else really. Then we saw the patient in this October, which was 2 months after the radioiodine scan. We did repeat the chest CT just to see what happened to those long nodules. The slice of CT with the arrows, the most recent CTs, and compared to the previous CT, we can see that the majority of nodules, they have decreased by half of their size, and some of them by 4 millimeters or 5. It was not half completely, but they have become smaller. And then we also obtained another neck ultrasound. There was no abnormality. So at the time that we saw her in October, her lab showed a little bit hyperthyroidism. We cut back a little bit the thyroid medication, but she's doing well. And we're going to see her in a couple of more months.
Dr. Khorsandi, how much do these CT scan lung lesions have to change before we know there were real change and slice variation? Do you kind of have a gestalt for that?
They're pretty accurate.
Yeah.
Especially these days with the new scanners, they're very accurate, and the measurements are, if it's half a size, it's half a size. Perfect.
That's great. So she clearly is responding. I mean, this is a pretty early response, 2 months to see some shrinking. TG's going down. Kate, you know, it's unlikely to cure these guys with one dose when we have macroscopic disease. So when do you sort of rethink about retreating, and do you use CT scans or TG? So how would you be telling her what's the likely next course here?
In this situation, we would probably standardly routinely book her up for a second therapy dose around 6 months. Sometimes if we think the disease is a bit more aggressive, we'll do it at 4 months, but routinely we would have pre-booked her for a 6-month repeat treatment.
David, let me have you weigh in. I used to automatically retreat people at 6 months and 12 months because we use a Roman calendar. And it seems we've fallen away from that a little bit, to sort of, wait a year or 18 months, get the maximum effect. I don't know if that's the right thing to do or not. What are you guys doing in terms of retreating when we know it's likely to be helpful?
Yeah, so we know this one's likely to have a good response. We know that it's reasonably indolent, and often we talk about slow to grow, and then it can be slow to go, as well. But typically, we would usually retreat somewhere between 6 to 12 months would be the time that would retreat. So maybe this one around 9 months, but it's not a hard and fast rule. Yeah. And
Naifa, what are you guys doing?
We, in general, don't automatically treat. So we would have waited probably similar to you. So we treat the ones, she had a beautiful response, and we'd wait out the year and see how she's doing. And I think that the data, depending if you look at the French data or other data, you can do either one, but we like to wait and save it. I think she had a beautiful response, and her NRAS mutation sort of semi-predicted that.
Yeah, and we tend to wait too, although I'm starting to think maybe we wait too long, but we're waiting. We tend to see a nadir around 18 months. TG tends to nadir around 18 months. Most of the shrinkage is around 18 months. So even when we wait, they often get retreated around that 18-month point. Okay. All right, Nazanene, that's a great case. It's nice to see. We often do the RAI refractory cases that don't really work. This is one that I suspect she's probably going to do well. And I suspect it probably did come from the thyroid, but as Naifa said, we've also seen the occasional struma overa do this exact same thing.
If I get those slides and they become small, I'll let you know.
Yeah, as if it's not.
Send them to me. Send them to me.
Send them to Margie. That's exactly right. Okay, let's move on to case number 2. We're doing great here, guys. I think this is Frank's case. You got this one?
Again, thanks for inviting us today. So my case is a 56-year-old gentleman that I met back in 2018, who, well, I didn't meet him then, actually. I met him a little bit later, and I'll tell you how I met him, who presented with a left-sided neck mass. And in December of 2018, he underwent a total thyroidectomy and central neck dissection with recurrent laryngeal nerve monitoring. 3 out of 4 nodes were positive for metastatic disease with positive margins. So you can see the pathology is a PT2, N1A. Didn't know the status of perhaps distant Mets, but a papillary thyroid carcinoma. And then in January, the patient received radioactive iodine, 100 millicuries. The thyroid globulin level was 799 with antibodies less than 1. And then this was about over a year later, presented to the ED with shortness of breath and lower back pain. And this is where I got involved. So the patient's wife was married before, and her husband was my patient with head and neck cancer. And so she called me and said, I'm desperate. I need you to be involved in his case. So he came into the ER, and chest CT was done along with an abdominal and neck CT that showed bulky mediastinal, pericardial, and bilateral hilar lymphadenopathy with the right lung micronodules, lytic lesion in the rib. On the right side, T12, at T12, L4, and S2 lesions. And then he underwent, while he was in the hospital, thyrogen stimulant iodide scan and PET scan. And here are the imaging studies we can see here. PET scan, you can see the intense uptake here. I don't know if anyone wants to comment about that, but
so not much on the radioactive iodine scan, and lots of places all over the place on the PET scan. So
correct.
telling us that it's that poorly differentiated. Okay, with you.
Exactly. So then in February of 2020, an MRI of the spine was ordered. The following month, palliative radiation therapy was delivered to the mediastinal regions, and then at T12, L4 in the right third rib at an outside hospital. And he received 3 fractions. Then in March, he presented back to the University of Michigan for worsening dyspnea, chest pain, acute lower back pain, and hemoptysis.
Okay,
And
pause just a second, Frank. Go backward.
Yeah.
So Kate, in terms of selecting for external beam radiation, they had selected a few places, mediastinum. When you're faced with all of this bone metastasis, can you sort of talk through for a second, sort of how you think what's going to be surgery, external beam? How do you sort of attack this?
Well, you want to look at the areas which are going to cause problems. Certainly we would be worried about leaving areas within the spine untreated. We have a spinal MDT with our spinal surgeons, and we usually discuss all of them through there to see whether they feel vertebroplasty or any decompression is warranted. But if there are multiple sites, usually they refer back to us to tackle with radiotherapy. If it's just a solitary lesion or just a few lesions, then we may consider stereotactic, which looks like this one may have had with 3 fractions. But if there are multiple lesions, then we probably just use standard radiotherapy and fractionate along with the other areas. With the mediastinum as well, again, we would consider treating that because of the potential of problems with obstruction due to volume of disease, and possibly for symptom control if they're getting cough, if there's hilar disease, for example, or any hemoptysis. And I suppose, so yes, it's mainly, and weight-bearing bones as well, of course. Those would be all my thoughts.
To try to maximize the localized therapy as much as we can. Okay, Frank, so keep going.
Okay, so this was the chest CT that was ordered in March of 2020.
Yeah, Dr. Khorsandi, any thoughts on that chest CT? And then David, Azita?
Just multiple nodular and ground glass appearance of bilateral mid and lower lungs.
So metastatic disease definitely, or right at the very top, or
yes,
infectious
yes.
on top of it, or
Yes.
Yeah. David?
Look, I just want to make a quick comment about the initial imaging. So if we just at that initial point of the administration of radioactive iodine, if there was a SPECT CT performed, I know it was done in another institution, but just thinking that the thyroglobulin is nearly 800, and we will always make sure we do a SPECT CT, and the reason is you'll pick up that non-iodine avid disease. There may have been pulmonary nodules, there may have been mediastinal lymphadenopathy, and at that point that there's metastatic disease. We'd often do an FDG PET then if it was non-iodine avid. You sort of get that impression of the extent of the disease, avidity, and that then informs the follow-up and management after.
Should have been a big red flag back in 2019 to have that high a TG and really not seeing much on the RAI avid, right? This guy almost certainly had at least some degree of bone mets back then, so that would have been a flag. Okay, Frank, go ahead.
Okay. And so total MRI of the spine was done, and there's a spot here. So several areas of altered marrow signal is noted within the spine, sacrum and pelvis, consistent with osseous metastases. Compared to previous outside MRI spine from February of 2020, there's now interval progression in several of these lesions, particularly at T8, T10, T12, L4, and L5, with mild enhancement of the anterior right lateral epidural space is noted at T12. No compression fracture is noted. Normal appearance of the spinal cord throughout, with no evidence of spinal cord compression. And finally, there's a lytic lesion focus surrounding the signal changes at the superior end plate at the level of L2.
So clearly we got structural progressive disease, probably not much of a role for radioactive iodine here. Naifa, I assume we're headed down a systemic therapy kind of pathway?
Yeah, so there's a couple of things, if you don't mind, I just would like to comment. So, this gentleman has fairly rapid progressive disease. When he presented, his complaint was both shortness of breath and lower back pain. And his lower back pain was from his spinal metastasis, but his shortness of breath, he had lung micronodules originally on the PET, which doesn't typically cause shortness of breath unless there's like lymphangitic spread. So I'm worried about bronchial compression there from those lymph nodes. So at the same time that I have, similar to what's already been said, we have neurosurgery and radiation oncology evaluate for, do we do stereotactic radiosurgery or traditional radiosurgery, but we'd also look at that mediastinum and see whether, a laser therapy for the hemoptysis, or even before we had the hemoptysis, could we have put a stent or something there, and even potentially consider radiation. But we have to keep in mind that down the line, if he progresses, he's going to need systemic therapy. And so if we think about radiation in the mediastinum, we're always worried about potentially a fistula if we're going to put somebody on anti-VEGF. So I'm just saying we would do the evaluation. I'm not saying we do the treatment, thinking about those things. But coming to the question that you asked, with the MRI of the spine, he had one a month before, right? And so March compared to February, there's already progression. That's extremely rapid, almost anaplastic, so he has thyroglobulin positive, radioactive iodine negative, progressive thyroid cancer. So definitely we're thinking about systemic therapy. We would order mutational testing or next generation sequencing in general, getting ready for systemic therapy.
Yeah, and I think the important point here is sometimes when these guys progress, we all just assume we grab for some systemic therapy. But your point is there's a lot of localized things that need to happen either before or concurrently, particularly in these rapidly progressive ones, right? All right, so Frank, where'd you guys go?
Yeah, and I think that's actually a really good point. And the fact that, he was clearly very symptomatic in a lot of, pain. And so that's why focal therapy was addressed. So next steps. So in March of 2020, palliative radiation therapy was delivered to the mediastinum, right lateral ribs, T9 through T12, total of 30 gray, 10 fractions to each site, including prior partial treatments from the outside hospital. NGS testing was ordered and was BRAF positive. In May, he was started on lenvatinib at 24 milligrams daily, and IV Zometa was initiated IV once every 3 months. And then in July, the dosage was decreased of his lenvatinib due to intolerance, primarily fatigue, hypertension that was having we had a difficult time controlling, and also he was starting to develop some proteinuria. And then in August, a CT and the neck and chest was completed. And here's what we have here in August of 2020.
Do you want me to comment?
Yes, please.
So he never had pleural effusions. Now he has pleural effusions, but he still has multiple nodular lesions. They look smaller since, I'm thinking it's the same cut. Some of the nodular lesions are smaller, but he still has this sort of interstitial pattern, and I don't like the pleural effusion.
Yes. Okay. So then in September, again, due to difficulty with intolerance, primarily related to fatigue, hypertension was controlled at this time, and proteinuria was also diminished with the use of an ACE inhibitor. But nonetheless, the lenvatinib was decreased to 10 milligrams daily. The following month, lenvatinib was stopped. The patient came in and said, I can't take any more. I'm fatigued. We repeated his urinalysis. He then developed more proteinuria. So we decided we just completely stop at that point. We waited a couple months and then he had a return visit to clinic with improvement in fatigue, but he had profoundly worsening cough. So then on the 20th of December, a CT of the neck and chest was ordered with home oxygen, and prednisone was started. And here is the, and I think I put the wrong date on there, and not 2022. When I was writing this, of course, I was thinking it's December, so it was this year, but it's actually 2020. So this is the neck and chest CT from December 20th, 2020.
So one thing that I don't like is on the coronal image, there's some soft tissue mass in the right side of the neck. And then on the lung, the pleural effusion is much smaller, but the nodular lesions are there, and it's as though he's developing like pulmonary fibrosis. the interstitial changes now have this chronic fibrotic appearance.
Yeah, Azita, I have a question. So would you call this some degree of lymphangitic spread?
Yes, yes,
Okay.
yes, absolutely.
Yeah,
I don't want to
'cause-
use that word because I don't like to use that word in imaging.
Okay.
I mean, that's really, I don't want Margie to get up.
I laugh at you.
And, you know, I can just see, I would use that word and Margie starts yelling at me. So yes, absolutely.
Not yelling, laughing.
Because, well, you'd be laughing at me because that's what I told myself. Well, you have a lot of lymphangitic spread here. So,
All right.
okay. All right. So next steps then. So then in December, due to the intolerance of the lenvatinib and the concern for proteinuria and some of these issues with hypertension, having a difficult time controlling, instead of going to a second generation cabozantinib or perhaps pazopanib or sorafenib, I decided to start dabrafenib, so BRAF inhibitor, since it was BRAF positive, 150 twice daily, and combining it with afatinib, 20 milligrams daily. His insurance company approved it, so we were well to go. And I treated him, and actually it was kind of interesting. For as concerning as these CT scans were, or are here at this moment, I did give him home oxygen. I did give him prednisone in addition to the treatment, and I hadn't heard from him. And so I was a little worried that maybe he had passed away, but no, lo and behold, he did show up and got his CT scan of the neck and chest. And it showed a significant interval improvement in the septal thickening in the lungs, as well as enlarged lymph nodes, consistent with improving metastatic disease. The osseous lesions are also more sclerotic than ever before. So here are the CT scans from December of 2020, and I brought them all the way up till the most recent date in October of 2022.
He looks much better. I mean, you can just, the nodular lesions have gotten smaller. The lymphangitic spread, if you look at those thickening of the septae, they're much, much smaller, and the pleural effusions have gone away. And if you see in 2020, the image that you gave me, that vertebrae is lytic. That lytic area is gone if you're sort of at the same level, which we are at the same level.
Yeah, right, right.
He looks much better. And then
And this is the CT of the neck.
It's the same. Look, the lesion, remember the right neck lesion I showed you on coronal? That lesion is gone. Yes.
Right. Okay. And so I did a summary of his serum thyroglobulin levels as I was going through this from 2020 up to the present. So you can see here, it started at 768. It rose to the 4,000s and 3,000s in May. And then you can see where the treatment was started. And then subsequently with the other treatment. So kind of bringing us up to the present point in August of 2022, actually his thyroglobulin level had gone up, and I'm continuing to follow him with CT scans. It's interesting, the CT of the neck and chest were read as stable, just as we had commented here earlier, but there was a new right iliac wing met, and a biopsy was performed. And here's the biopsy. I didn't, unfortunately, Marjorie, have the biopsy of the previous PTC columnar variant because it was sent back to the outside hospital and we couldn't obtain the tissue. But this is the new biopsy that I obtained on that left iliac wing.
Sure. So I don't know what the two immunos are. I assume one of them is TTF1. I don't know what the other one is. Maybe BRAF. I'm not. We don't use BRAF immunohistochemistry. But if you notice the nuclei in the lower west image, well, the nuclei don't particularly look like PTC, but that doesn't mean it's not follicular variant PTC. Again, it has to do with fixation and stuff that can change the typical histologic diagnostic criteria for diagnostic appearance of these tumors. So it could be anything. It's thyroid cancer, it's differential thyroid cancer. And of course, from this biopsy, I cannot exclude the possibility of poorly differentiated thyroid cancer, or what is now known as poorly differentiated, high-grade poorly differentiated thyroid, high-grade differentiated carcinoma. I like the memorial criteria diagnosis much better, but I'm going by the book.
Yeah.
So do we. I want to finish up on this one. Kate, this concept of switching between drugs, clearly it's worked here. And then we'll often see these people be stable on drug, and then they'll pop up with like one new bone met or one new lymph node met. So the logic of, do you continue the drug that's working on 99% and then just radiate this hip met, or do you change? That's a phenomenon that comes up, I think, fairly commonly.
Yeah, no, absolutely. And I think we would, if there's a differential growth in a single lesion, then we would definitely target that with some locally ablative, whether that be radiofrequency ablation, which we quite often use in the lungs, stereotactic radiotherapy or standard radiotherapy, or surgery if it's something else, whilst continuing the drugs for the rest of the disease. And we do see that. We do see it where you have what one lesion is growing. So you can just hold the disease for a little bit longer, but it usually does sort of preempt the progression of the disease as a whole, but it can just hold it for a bit longer.
Okay, Frank, and last two sentences about this case, and then we'll do the third one.
Sure. So in the current management is exactly what Kate has said. So I'm continuing the treatment, the systemic treatments, as well as the bisphosphonate therapy. And I've referred him to radiation oncology. They have seen him. We'll hold the medication and do the SBRT to the iliac lesion that will continue to follow. So just to summarize, this gentleman who presented with this very aggressive, poorly differentiating looking tumor actually went on disability as a fireman, actually has come off of disability, off oxygen, has gone back to play tennis, has gone back to work as a fireman. So I have to say that the medical management we've, have been able to offer these folks in the last, 10 years or so really has made a huge difference, not only in delaying the progression of disease, but also improving quality of life.
Awesome. Fantastic. All right, Dr. Wong, let's go to your case. We got this third case. I think what we'll do is probably concentrate on the first half of your case, which is the initial presentation and the surgery and that sort of stuff. And we'll see how far along we get, but we'll probably do the first half. All right, Dr. Wong, what do we got?
Yeah, quick question from the audience regarding a shortage of REI in Latin America with colleagues from around the world. Is anyone else experiencing that?
Yeah, in Europe, we're having some delays with access to iodine at the moment.
And has that changed your practice as a result? I assume it has.
It hasn't changed our decisions for proceeding with iodine yet, because we can get it. It's just been a matter of kind of weeks of delays and rearranging. But it is something we bear in mind, but it hasn't actually impacted on our management decisions yet.
Great. It's usually just causing a delay, right? Unfortunately, in radioactive iodine, if it's 2 or 3 weeks later or a month later, it generally doesn't make that big a difference. So we had case run into that. The other question that came up was from Dr. Goloski. There was a question when we were talking about retreating with radioactive iodine in the first case. Do we use TG to help in that? And we do. When we're trying to delay for a while, if the TG starts to rise, that's one of the indications for us to do it. If you're doing it automatically every 6 months, then I think it's probably a little less important. You still follow it, but in that treatment. Okay, Dr. Wong, let's do your first half.
Can I say one more comment, just because Naifa asked a question about the use of a MEK inhibitor, trametinib, which now is approved in patients who have BRAF solid tumors when other agents perhaps aren't available or warranted. So interesting enough, some work from your center at Eric Sherman Memorial shows this upregulation of ERB3 when we downregulate BRAF. Given the aggressiveness of this disease, and I didn't have the approval from the FDA yet, I decided to go with afatinib to see if they would cover it. So trametinib, yes, could have been used, but I think in this particular case, I was a little concerned that I may not get what I wanted. I don't have data for that per se, but I decided to go with the pan-HER inhibitor, and I think I just gambled right, and he continues to do well.
Awesome. Fantastic. All right, Dr. Wong, now let's do the first third of your case.
So I've got a 65-year-old woman who has a remote history in 2006 of having had radioiodine treatment for toxic multinodular goiter causing hypothyroidism. And this was successful when she was on thyroid hormone replacement. And then more recently, she had a 1-year duration of slow onset hoarseness of voice and shortness of breath. Her otolaryngologist noted that she had left vocal cord paresis that was apparently due to a very large thyroid mass with cervical lymphadenopathy. A biopsy of this left-sided thyroid mass in June 2022 was consistent with a Bethesda 6 papillary thyroid cancer.
Dr. Hartl, sometimes people tell us about this slow progression of, my voice gradually getting softer. Other times it's, I woke up this morning and I can't talk. Does either of those patterns help you understand, or it doesn't make any difference?
I'm not. Can you hear me? I'm not sure that it makes a difference particularly. I have patients who have vocal fold paralysis and have normal voice. So when you look, you've got this big mass and no voice changes, but the vocal cord is immobile. So I honestly can't say if you've got a big mass and all of a sudden things go wrong and they can't swallow and their voice is bad and it's going very fast, you kind of know that. But generally speaking, it's if you don't have a big mass that's progressing, the voice doesn't help me that much, really.
Gotcha. Okay.
Sorry.
Yep, that's one.
So her CT neck showed this left thyroid mass, which had internal calcifications, was having a mass effect on the trachea, causing the left vocal cord paresis, and there was left level 2 adenopathy. This is a representative slide from that.
Azita?
You see a bulky mass, left thyroid bed with probable, it's hard to say on this one image that there's tracheal invasion and there's probable invasion of the esophagus at the level you're showing this lesion. The image on the right shows that the lateral border of this lesion is irregular, so I would be worried about extra thyroidal extension. And of course, you see the vocal cord paralysis, but I don't see laryngeal invasion. I think the vocal cord paralysis is from recurrent laryngeal nerve at the level of the tracheoesophageal groove invasion rather than direct laryngeal invasion.
And in terms of optimal imaging for a case like this, is it just the CT with contrast? Is it MRI? Is it PET? What do you need to be able to help, guide the surgeon? Just the CT with contrast.
CT neck with contrast.
Perfect. Okay.
This was the ultrasound at the same time.
So the ultrasound shows this heterogeneous lesion. Most of the lesion is intense. It's isoechoic, the remainder of the thyroid gland. However, there are areas in the lesion that are hypoechoic that are concerning. There's an area that's hypervascular. On the images you're showing, I have a hard time seeing defining if there is extrathyroidal extension.
Yep, Dana?
Can I just say something quick, Mike? Sometimes if we're worried about kind of deep invasion into the esophagus, we'll ask for an endoscopic ultrasound of the esophagus. You can see the layers and you can see how deep that's going into the musculature of the esophagus. That can help.
No, absolutely. I do not. I'm sorry, because of the time I spoke very fast. So the esophagus is not up to the radiologist to evaluate. I could see a lesion that's inseparable from the esophagus. I can't tell if the esophagus is invaded or if it's just pushed. So that you have to scope a patient for that.
So Dana and Mark, even before we get to the intraoperative thing, I mean, there's some red flags going on here. So what are you thinking about, before you get into this mess, Dana, and then Mark, what are you sort of thinking about?
Well, yeah, I'm thinking about, first of all, very right off bilateral paralysis, wrist or tracheostomy. Well, we're going to tell the patient about that. This is probably a bad tumor, so we're going to do a total thyroidectomy up front anyway. I'd be worried about the esophagus to see how, but you really can't tell. You can get some ideas of how deep it is, but it's really only once you're in there that you can really see if you're going to be able to peel this away from the esophagus. So I would say in the tumor board, I would say, maybe I won't be able to get all this out. So we need to have a plan B afterwards.
Dr. Erkin, what are you thinking, Mark, when you're seeing one like this?
Yeah, very similar. I'm worried about whether my biopsy is representative of this lesion. It's a little bit of a red flag that we're sort of inconsistent that her voice has changed over the course of a year, rather than we've got somebody, as Dana had mentioned, that the cord just went out very quickly here. But I'm not sure you're going to see the critical portion of this tumor until you get to the deeper component. And that's probably where you're going to ask your pathologist to be of some help here.
Because we're probably betting this is not going to come back classic papillary, right? I mean, this is going to be tall cell or poorly differentiated or anaplastic or something bad, right? I mean, just from this presentation. Okay, what did we find at the surgery there, Dr. Wong?
Yep, so comments from our endocrine surgeon was that the prior RAI had made the right thyroid lobe atrophic and diminutive, but they said right away from the start, they could tell this wasn't a standard PTC. There was gross invasion of the trachea, esophagus, and it was surrounding the retrocarotid space. The frozen sections, interestingly enough, just came back as being PTC. There were no poorly differentiated components, but our surgeons, who are excellent, were only able to get an R2 resection, could only sort of remove approximately 60 to 70% of the primary mass. And then the frozen section of the primary mass still showed PTC.
So pop over and let's show the slides to Margie. So this is the pathology report?
Yeah. Pathology report is saying that there's invasive anaplastic papillary thyroid cancer with squamoid variation and positive lymph nodes. And these are the slides. I'll go through them. And should I do one by one or just keep?
Yeah, do one by one. And then you and Margie can kind of comment as we walk through these. What are you seeing, Margie? Help me out here.
Well, what I'm seeing is, and in my terminology, I'm seeing a PTC that's losing PTC-ness, meaning, you know, this does not look like a typical PTC. Let's keep going. Right, and so, oh, that's the frozen. Okay, that's very important because you can't look at the nuclear features in the frozen section slide. They're just, you can't set store by them. Next. All righty. I am thinking this is showing some squamous metaplasia, which I believe we're going to see better in the next slide. Okay, so if you look at these two islands of carcinoma, you know, if somebody showed them in a void, you couldn't even tell that this was thyroid cancer. It really does look more squamoid than anything else. And in my experience, and you know, in the experience of other head and neck pathologists, squamoid metaplasia is usually associated with grade progression. Now, occasionally I see squamoid metaplasia in a PTC, and I don't have the other hard features to say grade progression, poorly differentiated, et cetera, et cetera. I'll do some immunohistochemistry to back up my assertion, but I'll, you know, say something like that, you know, by here are the negative prognosticators in this particular case, and also there is this feature that can portend grade progression.
This is TTF1 stain.
Excellent. So, right. So there are 4 immunohistochemical markers that I use, and one of them is loss of TTF1. Now here you don't see any TTF1, okay? So that supports that this is grade progression. Sometimes in tumors that are, you know, you're catching them in progression, you'll have a decreased staining. So some tumor cells will stain, other tumor cells won't stain. And that actually means something. Now, on the other hand, 50% of anaplastic thyroid carcinomas are TTF1 positive, and I've seen them be diffusely positive. So that means the not seeing loss of TTF1, you know, cannot exclude the possibility of grade progression or anaplastic. Okay, next.
This is a PAX8 stain.
Oh, okay. Well, same here. Same as what I said for TTF1.
And this is a BRAF analysis.
Right. So again, we just go right to molecular. So I've never actually had the opportunity to use immunohistochemistry on BRAF, but looks BRAF negative to me.
And so to summarize, it was a unifocal 5 centimeter left lobe anaplastic thyroid cancer with lymphatic invasion, extrathyroidal extension, and positive margins. There were 3 lymph nodes involved. And obviously, this stage is 4B, all anaplastics are stage 4. It's got squamoid variation, and a proportion of it seemed to be differentiated. So the surgeons were wondering if any radioiodine could be considered. And the patient was put on cytomel and discussed with nuclear medicine by email. And we basically felt in nuclear medicine that it is unusual to have a preceding history of radioiodine treatment and then developing this anaplastic thyroid cancer years later. Disclosure, this was an outside case of giving the radioiodine.
Always is.
Because it's an anaplastic thyroid cancer with mixed components, we shouldn't really start with the radioiodine because it would delay treatment of the anaplastic component. And I felt like an FDG PET scan would be really helpful here to get an idea of the extent and for treatment planning purposes. Sometimes we do these with recombinant human TSH stimulation, but in a situation like this, that would not be necessary. And potentially, if everything was going well with the treatment and had the anaplastic component controlled, we could circle back to radioiodine. But if the hypothyroidism and TSH stimulation of that was going to be counterproductive, it may not be indicated.
Okay, let's pause right there. Go back for me, because we're going to stop the case right there. We got a couple minutes. Naifa, assuming this is a BRAF negative tumor, okay, because we've talked about BRAF positive before, you got partially resected disease in the neck. Tell me in a minute, sort of your approach here before we close this down.
Okay, so just going back to the original, when we had the CT scans and the surgeons have all commented that they suspected it was invasive, one thing is just to consider clinical trials for neoadjuvant, some sort of neoadjuvant therapy based on next generation sequencing, see if we can shrink it and then send them for surgery. This one's tough because it was already invading potentially trachea and esophagus, so whether we do some more massive resection. Now, post, you know that it's anaplastic component. I agree with everything that's been said, that you want to treat it like anaplastic. You want to treat the most aggressive. So if you did a PET scan and you don't see, you need to do staging of the full body, including an MR brain. If you don't see disease outside of the neck, then you treat it like an anaplastic thyroid cancer 4B, and we would do chemoradiation. And so we would have them see our obviously they've seen the surgeon, the radiation doc, and oncology to talk about chemoradiation with or without pembro, and then put them on a trial probably to do continued immunotherapy after that in the adjuvant setting if we didn't see disease. Got to give them the best chance.
That's awesome.
Mark. Let me just take Dana back to the day of surgery there. She's in the operating room. She's not getting any information from her pathologist on frozen section that this really is an anaplastic. So Dana, when are you going to make the decision not to be aggressive and try to get, treat this as an invasive, well-differentiated thyroid cancer? Because your pathologist isn't helping you out here.
So the question is, when am I going to stop? How far am I going to go? I would still be very wary because you get these heterogeneous types of tumors. And so the frozen section cannot be reliable. And I would be thinking tall cell actually, in maybe a case like this. I wouldn't be going toward a laryngectomy or a laryngectomy with esophagectomy. I would really try to be as conservative as possible functionally. The nerve is going to go because it's already paralyzed. But I would stop at, not resecting too much of the esophagus. And I would leave an R2 resection as well until we really know what's going on.
It's 9 hours.
Great. Perfect. Let me say thank you. These were fantastic cases. Thanks for the Michigan team. We got to talk about topics we haven't talked about in previous journal clubs. So great job and great presentation. Thanks to our panelists for a wonderful morning, and everybody have a wonderful day. Thanks, Dal. Bye-bye.
Thank you for inviting us.
Thank you.
Thank you.